So welcome everybody who's watching and now and in the future. This is a very important subject we're dealing with tonight, and it's a great pleasure to have two experts along with us, and I'll explain who they are in a minute. Basically, we're going to split the evening up into three sections, and there'll be a question and answer after each of these sections. And you won't be able to communicate with us directly verbally, but please, if you have any questions, put them in the chat, and my colleague John Anderson will field them. Now, our expert today is Anna Wilson, who's a consultant at St Mark's Hospital. And I've known Anna probably, I don't know, probably about 15 years or so when you were a fellow at St Mark's, I think it was. A very industrious person who's obviously achieved a lot, most of which you can see here has been in the field of inflammatory bowel disease. And she has a special interest in the management, prevention and treatment of precancerous lesions in inflammatory bowel disease. She does a lot of advanced therapy, and her original thesis under the supervision of Brian Saunders was in the diagnosis and assessment of dysplasia in IBD. And you can see that she's contributed to national and international guidelines on advanced imaging for lesion recognition in inflammatory bowel disease. And she has a substantial IBD practice. Now, I understand the guidelines, I think the new revised BSG guidelines have just come out recently, and Anna is on the guideline committee and she'll be updating us on what the latest guidance is. So what are our objectives? Well, I think it's fair to say that I don't think I've been anywhere or heard of anywhere that has a completely comprehensive and effective IBD surveillance service. It's very complicated to get this right for a whole number of reasons. So there's something about finding the patients and doing surveillance on the right ones and not people who don't need it. There's something about how you do surveillance, how you prepare patients. And then something that I'm particularly passionate about is how you share in the decision making. And we find quite a lot of our IBD patients are not keen to enter surveillance, particularly those that need it probably more than anyone else. So there's something about how can we involve them in their decisions to make surveillance more effective. And really, I can think of no one better to address these objectives. You will see that Anna's CV is pretty impressive, but I've seen Anna talk on this subject previously, and quite simply, she has star quality. So we're in for a treat this evening. The final thing to say is that we will like you to complete some feedback, what you liked about this evening, what you think we could have done better, and any ideas for the future are always welcome. Now, I think the final thing to say is that although we're getting an opinion from a specialist in a specialist tertiary referral setup, really, this subject touches all endoscopy practices everywhere. So this is a true everyday endoscopy subject. And I think there's some basic things that we need to get right. And we need to understand what our limits are. And Anna will be touching on this as well, and when we should be referring patients for further management. So I'm going to stop sharing now, and I'll invite Anna to share her own screen. And welcome, Anna, and thank you very much for being with us. We're really chuffed. Thank you.
Thank you so much for inviting me to come along. It's a real pleasure to be here this evening. Straight actually from my IBD clinic, where every other patient was a sort of second opinion on what we do with dysplasia. So I thought that was providing me quite a lot of for chat later on this evening. So as Roland has mentioned, we're going to split this evening into three separate talks, and we'll take questions after each one of them. But the first thing I wanted to address is exactly what has been mentioned before. It's the organisation of IBD surveillance. I will start by talking about what really is just a bit of a reminder for all of us, but I always think it's quite helpful to have a look at it again. And that is that even now, even with the old biological therapies and advanced imaging that we have, there is still remains increased incidence of colorectal cancer in IBD, and this data is particularly for colitis. And it's quite old now, but nevertheless, it's still very relevant at the moment. Sorry, I'm just gonna... Now, there is possibly a bit of declining risk of colorectal cancer in ulcerative colitis, and that's possibly related to the things that I've mentioned, which is improved therapies, particularly biological therapies, managing inflammation better, but also recognition and treatment of disease. I always go back to this slide of the importance of the carcinogenesis in ulcerative colitis. And it happens through inflammation. So it's an entirely inflammatory driven process that leads to damaged epithelium and leads to genetic and epigenetic changes, increased cell turnover, dysplasia, and cancer. And I think important thing to remember in colitis that unlike in sporadic pathway or compared to sporadic pathway, this